Thank you, sir. Good evening, all respected teachers and my colleagues. And first of all, thank you, Team Oncowin, for inviting me. Am I audible?
Yes.
Okay. Please share my screen. Slides.
No, sir, we can't see you.
Is it visible now?
Not yet, sir.
Can we share your slides?
Yeah, sure.
Sir, we have shared your slide. You just have to say next slide, we'll change the slide.
Okay, thank you. Next. Next. So, head and neck cancers is a global burden to all the worlds, and specifically in our Indian subset, which contributes to around 60% of the head and neck cancer worldwide. And annual incidence for head and neck cancer in India is around 2 lakhs per year. And this number is expected to be double by 2030. Next. So these are the risk factors for cancer, and specifically alcohol and tobacco are the major risk factor for head and neck cancers. And recently HPV infection is also a risk factor for head and neck cancers. Next. So this slide just shows just basic mechanism for developing cancer. This carcinogen metabolize in our body, and in healthy individual there are DNA damage is repaired, and this metabolite are detoxified in your body and excreted. But in head and neck cancer patient, this DNA damage does not repair, and it resulted in DNA damage in form of mutation, deletion, and amplification, and develop head and neck cancers. Next. So there are certain characteristics for HPV positive cancers, like there is young male or female, non-tobacco and non-alcoholic patient, and there is high risk sexual behavior. There are small primary like early T stage with advanced nodal stage, which suggests there is high chances of HPV positivity. And on radiological imaging, there is cystic nodal metastasis, and on histopathology there is non-keratinizing or basaloid SCC is more indicative of HPV positivity. And primary sites which is affected in HPV positive patient is oropharynx, and sometimes carcinoma of unknown primary with neck node is also an indicate HPV positivity. And as testing is done by P16 ISC test, which is a good surrogate for HPV infection, and preferably more than or equal to 70% staining is considered a positive test. As of now, in treatment, there is no difference between HPV positive and HPV negative patient. Next. So this is just a various testing method, and by ISC we detect P16 antigen. It's done on fresh, frozen, and FFPE tissue with a sensitivity of around 95% and specificity of around 85%. Next. So is there any difference between HPV negative and HPV positive disease in prognosis wise or in mortality? So answer is yes. Next. So this slide showed that mortality risk appear higher in HPV negative oropharyngeal cancer, specifically 2-year all cause mortality, and head and neck cancer specific mortality is almost 3 times higher compared to HPV positive patient in HPV negative patient. And second, primary malignancy is also high in HPV negative oropharyngeal cancer compared to HPV positive. So HPV positive oropharyngeal cancer carry a good prognosis, and HPV negative oropharyngeal cancer carry a poor prognosis. Next. This slide shows a subsite with overall survival, specifically oropharynx and hypopharynx. There is wide separation of curve, and this blue line indicate HPV positive patient, and black line showed HPV negative compared to oral cavity. Next. So in locally advanced squamous cell carcinoma of head and neck patient, which is around stage 3 and 4 AB, if upfront surgery, then based on histopathology report, we do radiotherapy plus or minus chemotherapy, and some very high advanced stage disease like T4 and N3. In that case, sometimes RT-based treatment was done. Anyhow, standard of care is concurrent chemotherapy plus radiotherapy, and platinum is the drug of choice. In some very high advanced cases, we do induction chemotherapy with TPF regimen, and in poor performance status and very old age patient who are not able to tolerate chemotherapy, in that case RT alone is also a reasonable option. And in today's topic, we are going to discuss mainly on biomap along with chemotherapy plus radiotherapy. Next. So there are some data which show that chemoradiotherapy is better compared to radiotherapy alone in locally advanced squamous cell carcinoma of head and neck patient. Next. Again, this is the certain characteristic of treatment modalities. Like in induction chemotherapy, we give TPF regimen. Sorry, that. Yeah, around 3 cycle was given, and in that case, progressive disease are seen in around 10% of the patient. And in definitive chemotherapy, we give weekly cisplatin or 3 weekly cisplatin, and in that case also there is progression of disease will see in 5 to 10% of the patient. Next. So until now, standard of care is CTRT, but what beyond CTRT for improving outcomes in locally advanced squamous cell carcinoma of head and neck patient? Next. So this last two, which is recently many trials are ongoing for these molecularly targeted agents and immunotherapy, specifically anti-EGFR inhibitor, cetuximab and nimotuzumab. Next. Next. Yeah. So in subsequent slide, 3 to 4 slides, we will see nimotuzumab trial phase 1 and 2 study, and after that we will discuss on one phase 3 trial which is done in PMH Mumbai, and it is this is best trial 2014, nimotuzumab with concurrent chemotherapy plus radiotherapy. Chemotherapy agent is cisplatin, and in patient with squamous cell carcinoma of head and neck. So this response rate at 24 week post treatment, so around at 6 months, chemotherapy plus radiotherapy plus nimotuzumab, almost 100% response rate was seen compared to only 70% in CT plus RT arm. So this Kaplan-Meier curve showed good separation of the curve. Red line is nimotuzumab plus CTRT, and blue line is chemotherapy plus radiotherapy. And median overall survival not yet reached at 5 years in nimotuzumab plus CTRT arm versus 21 months in CTRT alone arm. Next. So this is a PMH trial which also shows nimotuzumab with concurrent CTRT versus CTRT, and in all parameters like PFS, locoregional control, and 2-year overall survival, there is good separation of the curve, and in overall survival there is trend toward OS. So in this trial, we discussed subgroup analysis for oropharyngeal cancer in further slides. Next. So this is one Vietnam study. It is combined nivolumab with CTRT, around 87 patients, and all parameters like response rate, 1 year overall survival, 2 year OS, and 1 year, 2 year PFS. In all parameters are improved in nivolumab comparing to CTRT arm. Next. Again, there is one Singapore and Thailand phase 2 study. This separation of the curve showed that nivolumab plus CTRT is better compared to CTRT alone. Next. Again, one Chinese study, the number is very less, 36 patients, but yes, separation of curve is there, and all parameters are improved with nivolumab. Next. So this meta-analysis forest plot showed that nivolumab is better compared to CTRT arm. Next. Again, addition of nivolumab to CTRT improves survival rate 98% compared to CTRT arm only 91%. Next. 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 So any role of other anti-EGFRs like cetuximab and immunotherapy like pembrolizumab in locally advanced oropharyngeal cancer. Next. So there are studies done for cetuximab. As we already know, HPV positive disease is carry a good prognosis. So treatment de-escalation was tried, and it showed that compared with standard cisplatin regimen, cetuximab showed no benefit in terms of toxicity, but it showed significant detriment in terms of tumor control. So this Kaplan-Meier curve shows that red line is cetuximab plus RT compared to this blue line, which is cisplatin plus RT, and this second curve is with recurrence. So this red line, which shows higher chances of recurrence in cetuximab arm. Next. Again, this RTOG 1016 trial showed that radiotherapy plus cetuximab or cisplatin for HPV positive cancer, and this Kaplan-Meier curve showed that overall survival, progression-free survival, and locoregional failure is more with cetuximab arm. Next. There are limited data on pembrolizumab, though in the recurrent and metastatic setting there are more data, but in locally advanced oropharyngeal cancer there are limited data, and this pembrolizumab with CTRT did not improve overall survival in HPV negative patient compared to HPV positive patient. This blue line is for HPV positive. This is compared to HPV negative patient, red line. Next. And again, there is a did not improve overall survival in HPV negative patient compared to HPV positive patient. One ongoing trial for pembrolizumab with CTRT is ongoing, which is Keynote 412, which is phase 3 study, and I think the result will be published in 2023. It is pembrolizumab with CTRT followed by maintenance pembrolizumab. Next. Next. So this is from TMH study, nivolumab plus cisplatin plus radiation versus CTRT in HPV negative oropharyngeal cancer subset. Next, it is a phase 3 trial. So in background, we know that nivolumab added to CTRT improve outcomes in HPV negative patient, which has carry a very poor prognosis. And in method, there is a weekly cisplatin was given. Dose was 30 milligram per meter square, and nivolumab was 20 milligram weekly. So nivolumab plus CTRT versus CTRT, and HPV testing method was P16 by ISC, and outcome assessed were progression-free survival, disease-free survival, locoregional control, and overall survival. Next. So in HPV negative patient, already carry unfavorable prognosis, and there are some unique challenges like anatomical location, because open surgical resection is difficult and is a moribund procedures. Concurrent chemoradiation is the standard of care management, and there are incidence wise HPV positivity is variable across the globe. Like in North America, it carries 48 to 80%, but in Indian population, it is around 15 to 23%. Next. So all the parameters are comparable in both arms, CTRT versus nimotuzumab plus CTRT. Next. So in CTRT arm, around 91 patients were there, and in nimotuzumab plus CTRT arm, around 96 patients were there. And this 2-year PFS, locoregional control, and 2-year overall survival, all parameters are improved in nimotuzumab plus CTRT arm. Next. So in HPV negative oropharyngeal cancer, benefit of adding nimotuzumab is 2-year PFS benefit by 25.7%, with decrease in hazard of disease progression by 46%. 2-year locoregional control increase by 19%, with decrease in relative risk of locoregional failure by 39%, and overall survival benefit by 18%, with decreasing in hazards to death by 37%. Next. So again, this is Kaplan-Meier curve. So it's a similar result. PFS improved from 12 months to 35 months in nimotuzumab arm. Locoregional control is from 17 months to 60 months, and overall survival from 19 months to 35 months in nimotuzumab arm. Next. So now question is there any biomarker which predict response to nimotuzumab? So that answer is yes. Next. So this slide showed that this HIF-1 alpha is a prognostic and predictive biomarker in HPV negative locally advanced head and neck cancers. So high HIF-1 alpha significantly benefited with addition of nimotuzumab to CTRT, and high HIF-1 expression is a predictor of poor clinical response to CTRT in HPV negative patient. So HIF is nothing but a hypoxia inducible factor. It is actually a protein, one type of protein, and it's a transcription factor, and it is associated with development of cancer biology, and it is also associated with multiple other microenvironment of the cancers like tumor invasion, cell cycle biology, vascular invasion, and in before 2 years, in 2019, Nobel Prize was awarded for discovery of this HIF alpha in physiology and medicine.
Dr. Jignesh, if we can come to summary slide, please.
Yes, sir. Next. So quality of life is also next. Okay. So in this trial, nimotuzumab is also showed good quality of life, which is collected at baseline and 3, 6, 12, and 18, 24, and 36 months. Next. So addition of nimotuzumab to cisplatin-based chemoradiation in locally advanced head and neck cancer improve PFS, locoregional control, and DFS without negatively impacting quality of life. Next. So concluding that head and neck cancer is one problem in India because of its non-risk factor, mainly tobacco and alcohol, and majority of HPV negative cancer carry poor prognosis. Other anti-EGFR and immune checkpoint inhibitor have not shown benefit in this difficult to treat population, and nimotuzumab plus CTRT improve outcome in HPV negative patient without any negative impact on quality of life. Next. Thank you.
Thank you, Dr. Jignesh. Short and concise talk. I think we are running late, so we'll leave